Okay, let's get started here. This is the interesting case session. I'm Jim Howell, your vice president, and we're going to have 6 really great cases today. I want to thank all the previous vice presidents for helping to select these cases. By the way, you guys heard that rock music earlier? I told them to turn it down. They're having ZZ Top and Dwight Yoakam is playing in that little place right next to here. So if you hear it again, I'll go talk to him. So our first case is going to be from Vanya Arboleda from the Cleveland Clinic. Vanya, is she here? Okay, come on up.
I didn't know if I was going first, but my last name is always A, so it's always a predicament. Good afternoon. My name is Vanya Arboleda. I'm going to go back. I'm a second-year general surgery resident at Cleveland Clinic, Akron General, so close to main campus. I'm presenting the first case for interesting cases that we titled The Recurrence of Graves' Disease After Total Thyroidectomy, ? So, you're at your clinic and you have a very pleasant 60-year-old female who has sadly failed medical management for Graves' disease. Her endocrinologists have tried methimazole and beta blocker. However, she still has exophthalmos and palpitations, unintentional weight loss. She's referred to your clinic for definitive management of her Graves' disease. So this is where we're going to start. I'm going to ask a lot of questions and hopefully you guys work with me. So what type of labs and imaging would you like to start? Anybody in the audience? You can shout it out. Yes. Anything else? We would like any more imaging? Are we happy with just whatever we were told? So we're going to cheat here. So we want to confirm the biochemical diagnosis of Graves' disease. So yes, we're going to get T3, T4. As expected, they were high. The TSH was low. We were told that she had Graves' disease, so we confirmed with TSH receptor antibody, which was positive. And we also had thyroid-stimulating immunoglobulin, which was also positive. And the chronic thyroiditis, like Graves' disease, we also got an ultrasound. On the right side, we can see just a little enlarged gland, 6 by 2 by 3, as well as a left-sided gland that had 3 nodules, not significant, less than 1 centimeter, and they were all categorized at TYRS 3. So no need for any further FNA or following. So at this point, we have confirmed Graves' disease. We know that she's symptomatic, she's not controlled with her medical treatment. What is your preoperative plan for this hypervascular thyroid? I think we learned that yesterday as well. Anybody from the audience? Yeah, I think I heard it.
Lugol.
Yes, correct. So we gave this patient 10 days of iodine, and we continue her beta blocker and her methimazole. She was still, symptomatic, so as we learned yesterday with how to do the thyroid conversation, we want to keep her as controlled as we can, and the iodine will just help us with the vascularity. So what do we want to do in the operating room? I think we all know the answer, but if we can shut it out, that'll be great. Yeah, that's right. So we're going to do a total thyroidectomy with nerve integrity monitoring. In our case, we found some adhesions that were just consistent with chronic thyroiditis. We did nerve monitoring for bilateral nerves, and there was no complications, so the patient was able to go to PACU in a safe way. At your institution, how do you guys manage your post-op day 0 for a total thyroidectomy? You can just shut it out. I know it's different for everybody, so we check PTH. What else? Weight-based thyroid hormone. Anything else that people do differently? Stop methimazole. Yep. Anything else? When beta blockers, yeah. Something that I've been engraved by my mentor is that we always have a tracheostomy tray by bedside too. It's just something that we do at Akron General, but it's something that you learn as an intern. Yeah, so that's right on. In our case, we check calcium levels on post-day 0, and most of the time the endocrinologists are aware that the patient is inpatient, so they're gonna start her on thyroid replacement hormone when she goes home. So at this point, you're at your office, you're happy, you did a great job, no malignancy identified, the pathology on EPIC is telling you that you did a total thyroidectomy for what's now pathology-confirmed Graves' disease. Just nodules on the left, as we noticed on the ultrasound, but nothing concerning. But the patient presents to your office 3 months, or the endocrinologist's office, 3 months later, and she's complaining now of palpitations, increased appetite, unintentional weight loss. She's now on on the Synthroid, off the beta blockers, off the methimazole. So what are we thinking now as a group? Where do we go from there? Yeah, we check everything. We trust by verify, right? So at this point, we make sure that we're not making this with the Synthroid. She was on 150 milligrams, so maybe she was overdosed. That could be one thing. We want to make sure that after we take her off these medications, there you go. After we take her off these medications, she's still hyperthyroid. Maybe we induce this. And we want to make sure that we actually did a good job with the surgery. Like, did we remove everything? It's on the right parameters. In our case, we did a nuclear scan for the thyroid update. And so at this point, we were not super focused on what was going on. The nuclear medicine thyroid scan was an iodine tracer 123. The suggestive was very minimal thyroid tissue. It was only 2% after 24 hours, which is what we want, basically 0 to 3%. So we are still doing a good job as trainees. And the thyroid was still hyperthyroid biochemically. The T3 and T4 were elevated, and the TSH was low. So let's start again. What is our differential diagnosis now? We check a thyroglobulin. And
Have you looked at the ovaries?
We have not yet, but that's a good thought, yeah. What else? She's only taken the Synthroid that we stopped on, but no lithium. She's not taking any type of calcium. She's not taking any type of vitamin D. Yeah, anything else? That's the only sad thing. We did not do an entire scan. We only did a neck, and that was only 2%. So that was something that could have done. Yeah. Anything else? Any supplements? Nope. Nope. Was she eating at a restaurant that was recently closed down? No.
Did you,
No.
did you get a thyroglobulin level at any point?
We did, yeah, we
And
checked.
is it elevated?
They were not, no.
It was 0?
It was not, I don't remember the exact number, but it was low. Any other thoughts? She still has ovaries, that's a good question. So at this point, we're thinking, did we do a actually good job and we left enough tissue somewhere else, or did it come from the chest, from the abdomen? So yeah, that's where we went. So you could have done a CT chest, or you could have done a 2-view chest x-ray, or you could have done a CT abdomen and pelvis. In our case, working with endocrinology, we did do a 2-view chest x-ray, which was not significant for anything concerning, and we end up doing a pelvic ultrasound. We did find a right-sided cystic lesion, 3 centimeter. They categorized this as RADS3, which is low concern for a malignancy. It's not 0, but it's 1% to 10% as high. I think at this step, what is our differential diagnosis? What's our next step in the workup? Anybody? Yeah, a lot of good, great answers. So we did do tumor markers, and they were all negative. CA was negative, CA 125 was negative, CA 199 was negative, and inhibin beam was negative. We did consult a GYN because we were thinking maybe it's a teratoma, maybe it's a carcinoma of the ovary, maybe it's metastatic with unknown primary. Sadly, the patient was still symptomatic, so we did have to go up on her beta blocker and her methimazole. And we got an MRI to just delineate all the features. And this is the MRI. So now we have a mass that has enlarged, and it's more concerning. It was 3 centimeters on pelvic ultrasound, and now 6 by 5 by 4, and it's now categorized as RADS 4 and 5. So it went from low risk to almost high suspicious from an ovarian mass. So what are we thinking now? Take it out, yeah. Any differential diagnosis? Are we thinking we're still in the ovary, something else? Whole body scan, we can, yep. And anything else? Do we want to get? We did, and that was negative as well. Yeah, the whole neck, it was negative. I do have to say we did not do an entire scan for uptake of the thyroid, but we did get a gynecological oncology consultation, and they were very concerned that this was metastatic disease from the ovary, and they recommended a laparoscopic diagnostic, but at the end they end up doing a bilateral oophorectomy and salpingectomy, as well as total abdominal hysterectomy. They got some biopsies for the peritoneal and the omentum as well, just to see if there was any staging of this ovarian mass. And the final diagnosis, happily, was a benign rhizome ovary. Yeah, I think I heard it here. So yes, the patient had a right-sided benign teratoma that had just, as we go from left to right, some thyroid tissue with consistency with prior treatment. I think if we'd have gone whole, complete iodine update, as they were saying on the left side, maybe that would have speed up the entire process. But overall, the patient's doing very well. She has been discontinued of the methimazole, and she became hypothyroid. So now we started her on thyroid medication, and the follow-up have confirmed that she has now normal levels.
Were they just really concerned that they take out all of her belongings?
I heard half of it, but yeah.
Are they just really concerned that they take out everything?
They were really concerned, especially on the girls. So talking about timeline, and I read the notes too. So when we saw the time of presentation after the surgery was 3 months, and then within a month from the pelvic ultrasound, it had grown almost twice as much. So Gyn-Onc was very concerned that this was possibly metastatic disease from primary ovary to the neck to possible somewhere else. So that's why they were so aggressive with, as you can see, they took everything. Yeah. I'm almost done here with the time. So just major teaching points, take-home points is that less than 10% of the stromal exhibit as a thyroid toxicosis, and as a result, the stromal are often diagnosed after we remove the gland, and they have been confirmed with the pathology assessment. Identifying the cause of this hyperthyroidism is crucial, is critical, especially in patients that have high hyperthyroidism even after a total thyroidectomy. And I think that's time.
All right.
Thank you.
So Cord, would you give that patient radioactive iodine?
So that's why I asked about the TG, because it could be a viable tumor marker after the surgery.
All right. All right, well, we better move on to our next presentation. That's going to be by Peter Abraham from University of Alabama at Birmingham, An Unforgettable Vacation.
Thanks, Dr. Howe. And thanks to all of you for this opportunity.
All right, so our patient is a 49-year-old female. She's an operating room nurse with a history of asthma, and she experienced chest tightness and palpitations while she was at the beach on vacation with her family. Her symptoms progressed to weakness, dizziness, nausea, vomiting, so she presented to a local hospital on the beach. She was hypoxic upon arrival, so was quickly placed on BiPAP. She was then transferred to a local hospital nearby in the city for further evaluation. So this is early, but I want to get initial impressions and want to see what additional information the audience wants. Vital signs, great place to start. What else? Yes, past medical history we'll get to. Other thoughts? What are people thinking at this point? Theo? Other thoughts on a differential? Anaphylaxis? Did I hear COVID? COVID pneumonia? Okay. So for medical history, so 1 month prior to this presentation, the patient actually had been admitted for an NSTEMI at her local hospital. Reportedly, the left heart cath was negative. She had a preserved ejection fraction on the echo. However, they did note dilated cardiomyopathy on the cardiac MRI. So she was discharged home with an aspirin, beta blocker, a statin. They put her on a cardiac event monitor. She followed up with a cardiologist. She was cleared, and they told her, you're fine to go to the beach for vacation. Her other past medical history is listed here. As you can see, nothing contributory. So going back to present day with our current presentation at the beach. So she got a CT scan of her chest, which revealed diffuse pulmonary edema. She then had an echo. So remember, the echo previously was normal. The echo now has an ejection fraction of 10%. The patient became unstable, so there are the vital signs. She was unstable, hypotensive, despite inotropes, so she was taken to the cath lab. They placed a percutaneous ventricular assist device. However, there's no improvement in her hemodynamics. So they ended up cannulating her for VA ECMO, and she got intubated in the cath lab. So then they called our institution. They wanted a consideration for LVAD and or cardiac transplant. So it was transferred to the cardiac transplant ICU at UAB, given the rapid onset cardiogenic shock as well as the decompensated heart failure. Metanephrines, yes. So that leads me to the next question. So what workup do you want to get at this point? So the patient has now been transferred to our institution, cardiac transplant ICU. Metanephrines, what else? CT scan, yes. TSH. Those are all things that we were thinking as well. I hear chromogranin as well. So I'll show you the labs, and then we'll go over the CT scan. So as you can see, white count was elevated, had elevated liver enzymes as well as cardiac enzymes, not surprisingly. Multiple derangements on the general chemistry, including lactic acidosis of 9.3, multiple electrolyte derangements. Blood gas, as you'd expect, this patient is intubated at this point. I heard TSH, so thyroid function panel was normal. So next, I heard about a CT scan. So we'll walk through this. I did try to get a little bit of the thyroid in the picture here, so that's why I included the neck, which was unremarkable. We'll scroll down through the chest. You'll start to see a little bit of atelectasis and some bilateral pleural effusions. You see the NG tube there on the stomach. You also see the patient's cannulated for ECMO, so you see those lines as well. And then you see that 4 centimeter adrenal mass on the right side. So it was not. So yes, good question. I hear about that CT scan of the chest at the outside hospital, at least not in the reports that we have from that CT scan. So you have all this information now from the workup. What do people want to do next? Metanephrines and block. So in the interim, this patient was evaluated by our cardiac team, was deemed appropriate for ECMO decannulation. So they did decannulate, they extubated the patient. The patient did remain on pressors with balloon pump support, did require continuous renal replacement therapy at this point. We did send off metanephrines. It is a send-out test for us, so that required about a 5-day turnaround. And we did block. So we started doxazosin at this point, even prior to the return of those labs, given our high suspicion for a FEO. However, after starting doxazosin, the patient then struggled with hypotension, had to go up on the pressors, and then began having pressure-induced ischemia at the tips of her fingers. So what will you do now? I heard operate, I heard localization. Adrenal embolization, okay. I guess raise your hand if you would operate at this point. Okay, I heard calcium channel blockers. Oh, yeah, so raise your hand at this point if you want additional medical therapy, additional blocking, you want to do something else at this point to block this patient further. See a few hands. And that show of hands for embolization, I heard that as well. Okay. So the decision was made, we actually held the doxazosin until the metanephrines returned. It was going to be 2 days at this point. So 2 days later, the metanephrines returned with the metanephrines 40 times the upper limit of normal, Normet 40 times, and the metanephrines 24 times the upper limit of normal. So we had a multidisciplinary discussion to determine what the proper balance is of supporting the cardiac function and perfusion for this patient, while also making sure that we sufficiently block the tumor catecholamines. So what would y'all do at this point? So the echo we had was still the 10%. Same thing.
Can you try metyrosine? Do you think that would work?
Yes, I hear metyrosine. What do people think about that? Yes. And so the decision was made to start metyrosine, as well as to go back on doxazosin in a rapidly titrated fashion in order to prepare the patient for an operation. So we did this following 48 hours of that alpha blockade. The patient was taken for a laparoscopic right adrenalectomy. So in the operating room, there was substantial hemodynamic instability despite full balloon pump support. So at this point in the operating room, we've successfully insufflated the abdomen. We've started a laparoscopic liver mobilization on the right side. And then, anesthesia is telling us, the pressures are dipping, systolics are 60s and 70s. They're bumping up the pressors. So we're up to 3 pressors at this point, from starting at 1 pressor at the beginning of the operation. Squeeze the tumor, I hear. What else? What are other thoughts? I hear a trial of desufflation. So we did, with desufflation, it did seem to improve. And so we converted to an open operation. So we converted from laparoscopic to open. We were able to successfully complete the operation open. The patient did remain on 3 pressors upon conclusion of the operation. And then here you can see a gross specimen picture on the left there. I use a representative sample from our pathologist, and there you can see on the right side, it does appear to be a medullary origin consistent with the pheochromocytoma. That was confirmed on pathology. It was a 4-centimeter pheochromocytoma. You can see the details there. PAS score was 4, margins were negative. So postoperatively, the patient recovered pretty quickly. So post-op day 5, she had renal recovery. Post-op day 6, the percutaneous ventricular assist device was removed. Her echo at that point showed an ejection fraction of 50 to 55%. She was off all pressures by post-op day 7. Prior to discharge on post-op day 19, an echo was repeated and showed stability of her ejection fraction with no significant abnormalities. Then she was discharged on post-op day 21, back to her home in the Midwest for rehab. So teaching points for this case is 1, that a pheochromocytoma-induced cardiogenic shock does require a careful balance of supporting cardiac function and perfusion while also making sure you're blocking those excess catecholamines. You may have to alter your standard alpha blockade pathways when you're managing these patients that have a decompensated heart failure due to a pheo. And then finally, have a low threshold to convert to an open operation for these patients that have pheochromocytoma-induced cardiac dysfunction. So thank you all. Welcome any additional questions or discussion that we may have.
Nancy Perrier.
Did you do genetic testing?
So the patient does, live up in the Midwest. She was just down on Gulf Shores for like a week of her beach vacation. This turned into like a month ordeal.
We have genetic testing up there,
And
Just
what's that? So I don't know the full like long-term, course of her, unfortunately. So I don't know subsequent work of genetic testing, but she was plugged in with care in the Midwest.
It is our responsibility because she's at a risk for bilateral disease and for recurrence. And,
Yes, yes.
And knowing that about 40% of those, right, with that size.
Yes. Dr. Lindeman brought up that she's well cared for now by Dr. John Olson, so she's in good hands.
Quick question
Courtney?
too. So did you guys go back and pull any of her data from her original cardiac evaluation? Because obviously, I mean, that's what triggered everything the first time around, right? So you said she got stented. So I wonder, you said she was like 46, 48. Did she really have any true underlying coronary disease, or did they just stent something that looked like maybe a little narrowed and they glossed over all of this for her diagnosis? I'm just curious.
Yeah, I don't believe she was stented at that initial. She had an NSTEMI, and then, yeah, it was an NSTEMI. She was not stented, at least as far as I know.
Courtney Lee?
Yeah, Courtney Lee, Lexington, Kentucky. For all of our trainees and junior young surgeons, I presented this exact case at this exact conference over 10 years ago, and guess who never published it? So, publish your stuff so other people can help. I remember being in the ICU in the middle of the night, like, what the heck, my tyrosine. I called Clive Grant. He was at the zoo with his kids. Mayo was like, he's retired. I'm like, I don't care. I saw this paper. I need to talk to the man. But anyway, and he did. He answered, and he's like, what do you have? I'm like, I have this dude on ECMO, and he's got a FIO, and like, they want me to take it out right now. He's not blocked. How do I block him? They don't want me to give. You know, it's going to hurt his heart, like you described. So publish your stuff, unlike me, who doesn't like to do so. So good job.
Thanks, Dr. Lee. I appreciate it. We will definitely be submitting it for publication.
These are some of the hardest cases we'll ever face. About every 3 years, I get this call from our cardiovascular center, and I know what it is. And over the years, you get a few of these, and I just want to bring to the group's attention. One time I got called, a man who was young, 25 years old, sort of like this, but his EF was 10 to 15. He actually needed an extracorporeal circuit, like a LVAD extracorporeal circuit. They scanned him, and he had a left adrenal mass. And his normets were 6 or 7 times the upper limit of normal. So the obvious diagnosis is the same thing here. We took him for retroperitoneoscopic, so we flipped him with these extracorporeal cannulas, the whole thing. We took it out. He did okay. And do you know what it was? A ganglioneuroma.
Yeah.
And I couldn't make sense of this, but it turns out when you're dying from heart failure from another cause, your normets are through the roof. And so I got tricked into Takotsubo when it wasn't, in fact, a Takotsubo. So if you ever get this call, definitely be on the lookout for that. If the epi is high, if the mets are high and the normets, it's almost certainly this, even if they have an incidental adrenal mass. Yeah, great job on this case.
All right, Naris, quick question.
No, I was going to say the same thing. I've had, heart failure with 2, 3, 4 centimeter nodules coming in, and all these numbers are up, so be careful with those things. But this one is pretty obvious that the person is an extremist, right? So be careful. If you have time, do a dotatate just to make sure. But this one is not. This one's clear, so.
All right. Thank you all for the discussion.
All right, the next talk is Ross Mudgeway from Weill Cornell. And just because you guys may not know the order, after Ross will be Mac, and then Rui.
All right. Hello, everyone. My name is Ross Mudgeway, and I'm the Endocrine Surgery Fellow at Cornell this year. I will be presenting an intriguing interaction between a RET mutation and IGF-2 secretion. So the patient was a 20-year-old female who initially presented to her PCP for episodes of sudden lightheadedness, weakness, and feeling shaky over the last 2 years with recent increased frequency. The episodes occur 1 to 2 times per day and would last approximately 20 minutes. Associated symptoms included sweating, blurry vision, headache, and fatigue. The episodes occurred at random. She reported that the episodes can occur in any position, sitting, standing, or walking. The episodes did not occur with changing positions and never happened during exercise. In between episodes, she reported having normal energy levels and was able to concentrate in school. She reported that the onset of symptoms was not related to meals, and the episodes can occur 1 hour or several hours after having a meal. And she said that when she starts having symptoms, she will eat a snack and her symptoms usually resolve within 20 minutes of eating. She said that during one of the episodes, she used her mother's glucometer to check her finger stick blood glucose, which resulted as 53. So what classic triad of symptoms does she have? Yes, she had Whipple's triad, which includes symptoms of, she has, Whipple triad, which includes symptoms consistent with hypoglycemia, a low plasma glucose concentration when symptoms are present, and resolution of symptoms after the plasma glucose level is raised. In patients without diabetes, hypoglycemia symptoms are nonspecific and can include autonomic responses and neuroglycopenic symptoms as shown. For patients that meet the criteria for Whipple's triad, a thorough history and physical exam can help identify the most likely etiology and guide subsequent management. And for our patient, she had no contributory past medical or past surgical history. The medications she reported taking were fluoxetine for anxiety and an oral contraceptive pill. She had a family history of Graves' disease, but no thyroid disease in herself. Her family denied any history of pancreatic tumors or MEN1 syndrome, and her physical exam was unremarkable. So what is the differential diagnosis? Yeah, I heard a few of them. In a non-diabetic patient, the differential is broad and includes side effects from medications such as exogenous insulin use or sulfonylurea use, alcohol use, adrenal insufficiency, endogenous hyperinsulinism, non-islet cell tumor hypoglycemia, critical illness, chronic malnutrition, and other causes. So what are some of the lab tests that you would order? Anyone? Yes. Yes. Yes, I heard a few of all of them. And since our patient had an increasing frequency of symptoms, but only one recorded low blood glucose level, she was referred to endocrinology for evaluation if her symptoms were related to blood glucose. She underwent a thorough laboratory workup as shown with fasting labs. And at the time of the fasting lab draw, her results were notable for an elevated insulin-like growth factor 2 and phosphatidylethanol levels. She reported that she had consumed alcohol prior to the lab draw, which likely explains the elevated phosphatidylethanol level. Of note, her total insulin and her C-peptide levels were normal, and her sulfonylurea screen was negative. So besides imaging, what additional studies can we order in this workup? Well, it's something that we don't usually do as endocrine surgeons, but she was admitted for a mixed meal test and for a 72-hour fast to further evaluate her hypoglycemia. As we know, both of these tests are not commonly ordered by us. However, they can be an essential diagnostic tool to narrow down a diagnosis when a patient presents with unexplained Whipple's triad. A mixed meal test is for patients who experience postprandial hypoglycemia. And while institutions have different protocols, the test typically consists of a baseline lab draw followed by consumption of a well-balanced meal, and then the patient is monitored with serial lab draws. The test is terminated when the patient develops hypoglycemic symptoms or 5 hours elapse and final labs are drawn. For our patient, she remained normal glycemic and did not experience symptoms for the duration of the mixed meal test. Of note, her IGF-2 level on the baseline lab draw was significantly elevated. She then continued on to the 72-hour inpatient fast. Protocols also differ by institution, but this is a general summary of the key points of a 72-hour fast. The patient is NPO, but can consume beverages that are calorie or caffeine-free. Blood glucose is measured every 2 hours, and then when the patient experiences hypoglycemia symptoms, the endpoints are as shown, and when an endpoint is met, labs are drawn. And finally, a glucagon challenge test is then performed at the end of the test. So for our patient, she had mixed results from the 72-hour fast. Her blood glucose, C-peptide, and proinsulin were appropriately low, which is not consistent with an insulin-mediated hypoglycemia. Her elevated beta-hydroxybutyrate indicated that ketogenesis was not suppressed, and this is not consistent with IGF-mediated hypoglycemia. However, after administration of 1 milligram of glucagon, she had a significant increase in blood glucose, defined as a change of greater than 25, and this may suggest an insulin or IGF-mediated hypoglycemia. Thus, the results were not consistent and did not give us an answer or clarity yet. So what would you order next? Yes, so she hasn't had any imaging yet. So a MR enterography was first ordered, and it was ordered to rule out any masses or lesions in the GI tract or pancreas, such as a neuroendocrine tumor. The MRI was overall unremarkable. The small bowel was appropriately distended and normal in caliber. There was no foci or inflammation in the bowel, and no fibrofatty proliferation of the mesentery was noted. The liver, gallbladder, pancreas, spleen, and adrenal glands were unremarkable, and no masses were noted. She then underwent a PET CT. A regular CT was not ordered, but this is the PET CT scan. As you can see here, there was no FDG activity in the small bowel, large bowel, mesentery, pancreas, or adrenal gland. There was no FDG activity noted in the proximal stomach. However, most significantly, an FDG avid right thyroid nodule was noted. Also, multiple FDG avid cervical lymph nodes were noted bilaterally.
Ross, would you think that an FDG PET would be the thing that would show up like an insulinoma or something, or was this just scanning the body?
You can do an FDG or a dotatate PET scan. For this patient, she had an FDG done, but she could have been considered for another PET CT as well. So she then underwent a thyroid ultrasound, which demonstrated a 1.7 centimeter right lower pole solid hypoechoic nodule with punctate echogenic foci and peripheral calcifications, TIRADS 5. The left lobe did not have any suspicious nodules. Multiple bilateral enlarged heterogeneous cervical lymph nodes were noted for suspicious for nodal metastasis, and here you can see sagittal views of a 2.9 centimeter right level 4 node and a 2.4 centimeter right level 2 node. FNA biopsy of the right thyroid nodule demonstrated papillary thyroid carcinoma, and biopsy of the right level 4 lymph node demonstrated metastatic disease. She then underwent a total thyroidectomy, central compartment neck dissection, and bilateral modified radical neck dissection. She did well postoperatively and was discharged home on post-op day 1. Her surgical pathology demonstrated multifocal papillary carcinoma, classic type, with focal features of diffuse sclerosing variant. The margins were negative, and there was no angioinvasion or extrathyroidal extension, but lymphatic and perineural invasion was reported. And 41 out of the 118 lymph nodes were involved, and there was no extranodal extension. A TSO 500 molecular analysis identified a CCDC6 RET fusion, formerly a RET PTC1 fusion, as well as a PARC2 mutation was identified as well. So at her follow-up visit 1 month later, she reported that her hypoglycemic symptoms had resolved immediately after surgery, and she was no longer experiencing the symptoms that had prompted the hypoglycemia workup. She has remained asymptomatic, her IGF-2 levels have decreased and are now within normal range, and she underwent radioactive iodine treatment. At her most recent follow-up, she is doing well and has no evidence of metastatic disease. So in conclusion, this case highlights that persistent autonomic and neuroglycopenic symptoms associated with hypoglycemia should prompt biochemical workup for hormonal etiology and expeditious multidisciplinary management to facilitate timely diagnosis and treatment. Functional imaging studies, such as an FDG or a dotatate PET CT scan, can reveal an occult malignancy causing a perineoplastic syndrome that may not be captured on first-line imaging. And although very rare, perineoplastic syndromes associated with thyroid cancer can be considered in the absence of any other identified etiologies. Thank you.
So Ross, why do you think she had elevated levels of IGF-2? Do you think any of these mutations in the tumor caused increased expression of that, or where did that come from?
That's certainly a possibility. In my own literature review of patients with elevated IGF-2 and thyroid cancer. There haven't been any known associations, particularly with the CCDC6 and RET fusion. I think that's something that can be further studied, especially in the setting of the increasing prevalence of molecular tests identifying these fusions.
And that PARK2 gene, that's a Parkinson gene, right? So you don't think that has anything to do with it?
I think for this patient, I don't think the PARK2 mutation was a contributing factor based on the genetic report that we received.
Barb?
Two questions. One, is there a stain for IGF-2? And the second question is, we were sitting here wondering, and maybe it wasn't you that it was done by the endocrinologist or medicine team, but MR enterography was an interesting first choice for an imaging study. I think we skipped right over the physical exam, and that nodule looked pretty close to the surface, and those lymph nodes were kind of big. So what was the physical exam of the neck?
Right, her physical exam was negative. There was no palpable nodules or palpable cervical lymph nodes, surprisingly, at least noted by the PCP and the endocrinologist, which had evaluated her before we had seen her, and no ultrasound had been done. And they had ordered an MR enterography as well. They just did not do a CT scan or a colonoscopy or upper endoscopy. I think maybe because of her age, being 20 years old, they wanted to jump to an MR enterography, but we saw her after the fact. And your other question, sorry, about the IGF-2 staining. It was requested, but it was never obtained. She had seen a few other institutions, and this pathology slides had tried to be obtained to get the IGF-2 staining, but it seems like there was no way to actually get the IGF-2 staining. I guess it's pretty uncommonly done, at least to the institutions that had seen her in New York City. But that would have been helpful, and it would have been nice to have shown those.
Are you going to give her radioactive iodine?
Yes, she had received it postoperatively.
All right, well, great job.
Thank you.
Okay, the next case is going to be from Mac Quinn from the University of Indiana School of Medicine.
Good afternoon. Thank you for this opportunity to present our case. My name is Mac Chin. I'm a PGY 3 in general surgery at Indiana University School of Medicine. And our case today is titled Hypercalcemia Twist, A Tale of Two Calcium Disorders. I have no relevant disclosures. We begin our case with patient M.O., who is a 55-year-old male who was referred by nephrology to endocrinology in 2022. Previously had been seen by endocrinology in 2012 due to hypercalcemia with progressive instances of symptomatic nephrolithiasis and chronic kidney disease, along with osteopenia. Clinically, however, the patient remained very well appearing and continued to play a very vigorous golf game. He was then referred to endocrine surgery for additional evaluation. This is a sample of relevant labs at the time of presentation on referral to endocrine surgery. So the initial question is, what would this group do next? Yeah, absolutely. I heard urine. That was, to my knowledge, obtained and relatively benign. PTH-related peptide was obtained and was mildly elevated. However, given his long-standing hypercalcemia, the endocrinology team favored that this was a result of that. Come again? So endocrinology suspected of vitamin D-mediated hypercalcemia. And as part of their workup, they ruled out several common contributors along that etiology. A normal ACE level made sarcoidosis unlikely. A negative PPD ruled out granulomatous tuberculosis. Urine histoantigen levels were negative, ruling out histoplasmosis. And SPEP and UPEP were negative, ruling out a plasma cell disorder. Given these findings, what next steps would be considered? Yes, sir. We did not obtain a PTH from another lab, but that is a good thought. Biotin, I do not recall a biotin being obtained. No, he was not taking biotin. A vitamin A level, I don't believe a vitamin A was obtained, no. Urinary calcium, I believe, was normal to the upper limits of normal. I've never heard of that. Sorry, you're kind of throwing me for a loop here. All right. Bone scan, DEXA was done and showed had a T-score of negative 1.4. So we proceed. Genetic testing was obtained. An initial testing panel consisted of the following 7 genes. However, initial testing was negative for any deleterious mutations. So along that thread, are there any other genetic disorders that this group would test for? Follow-up testing revealed 2 heterozygous loss-of-function mutations in CYP24 alpha 1, suggesting a biparental inheritance pattern. Our patient was subsequently diagnosed with CYP24 alpha 1 related hypercalcemia. At this point, I feel it would be beneficial to have a brief primer on this condition, as it may be the first time a lot of us are hearing about it. It certainly was the first time that I had heard about it. CYP24 alpha 1 is a member of the famous P450 family of enzymes involved in metabolism. Specifically, it includes an enzyme critical to vitamin D3 degradation. It was first described in a clinical aspect in 2011 in a pediatric population, specifically for its contributions to idiopathic infantile hypercalcemia. The incidence was estimated at roughly 1 per million. There are documented case reports of this condition, which number in the hundreds. However, in our literature review, the number of case reports necessitating operative intervention number in the single digits. Unfortunately, our patient continued to decline in terms of clinical progression continued. Endocrinology initially attempted medical management with cinacalcet, Prolia, and consideration was given to possibly using fluconazole and lilendronate. While the first 2 medications were trialed, the latter 2 were not, given concerns about lack of efficacy, as well as patient concerns about side effects. Unfortunately, our patient continued to progress. Despite lifestyle modifications, including avoidance of sun exposure, limitations in vitamin D-rich foods, the patient continued to develop increasing calcium levels, peaking at 14.2, and at that time, his creatinine was 2.42.
Did you get a repeat PTH now?
Well, we'll get to that in a moment, sir. But while we are on the subject, if there's any other testing that would like to be obtained by this group. Ultrasound? I heard ultrasound. I heard 25 hydroxy vitamin D and 24-25 hydroxy vitamin D. Okay. 125. Okay. And PTH again. Okay. So this is where the twist in our title comes from. While initial PTH was well within the normal range, a recheck in December of 2024 was subsequently elevated at 93, and a recheck of that demonstrated a PTH of 122 with a calcium level of 13.9. Patient's creatinine peaked at 3.41 in July of 2025, and also the patient is also noted to have developed an acute pulmonary emboli requiring thrombectomy by IR at the same time. So So at this time, endocrine surgery was re-engaged given the new elevation in PTH. And as next steps, I've already heard it spoken by the group here. We obtained an in-office ultrasound as part of our re-engagement and consultation. And this is a representative image of the in-office ultrasound obtained, showing a candidate lesion on the right inferior third of the thyroid, measuring about 0.7 by 1 centimeters. Not shown was a similar lesion that was raising concern on the left side that was much smaller at 0.4 by 0.6 centimeters. Additionally, a SPECT CT was obtained. This is a representative image showing areas of concern that our radiology colleagues highlighted, showing sestamibi avid lesions at the bilateral inferior third of the thyroids. At this time, I would like to pose to the group what options would be considered. Specifically, foregland versus localized exploration. Foregland. Always foregland. So we proceeded with a foregland exploration or bilateral parathyroid exploration, and we discovered enlarged descended bilateral superior glands, which were resected. Bilateral inferior glands were appreciated in the operating room and were appreciated to be normal, so those were left in vivo. Our pre-excision PTH was measured at 151, but our post-excision of our second parathyroid, 10 minutes afterwards, excision, our PTH was measured at 20, meeting Miami criteria for operative cure. On postoperative follow-up, our patient continues to do very well. He's discontinued his cinecalcet since his operation. His PTH remains normal. We actually followed up on a set of labs obtained 4 days ago, and his PTH was actually at 24. His calcium is exactly 9.9 4 days ago, and he's back to playing a very good golf game. Our take-home points for this case. The first step is basically knowledge of that this gene exists. CYP24 alpha 1 encodes enzyme that is critical to vitamin D3 degradation. Loss of function mutations present challenges in degradation of vitamin D3 and can lead to a vitamin D-mediated hypercalcemia. Preoperative testing can include genetic testing, as was done here, or consideration of a 25 OHD and 24-25 OHD ratio. In a past case report, a ratio of greater than 25 was described as suggestive of a diagnosis of CYP24 alpha 1 hypercalcemia. Specifically in our case, I'd like to mention that we believe these two pathologies, the CYP24 alpha 1 mutation and the primary hyperthyroidism, are distinctly separate pathologies. We do not feel that they were necessarily linked, which is commiserate with the number of case reports describing this condition. I'd like to thank everyone for this opportunity to present this interesting case. I'm happy to take any questions.
Well, how many people in the audience think that these things are not linked? I would think with, abnormal vitamin D metabolism that would have played a role in this. Does anybody else feel that, or? And if so, then maybe you should have done a subtotal parathyroidectomy. Because you're going to go back, you might go back. I don't know, would everybody have just taken out 2 glands, or would people do a subtotal in this situation?
And those can help understand how long the disease has been going on and process, and that might give you some idea of how to expect bone hunger or whatnot. It might give us some information about
That's good to know. Thank you very much for that insightful comment. I think that's a good point to raise as well about kind of casting a wide net and running it by 2 labs. I appreciate that.
I have a question for you.
Yes, sir.
So why, you haven't done anything now with the, your CYP24A1 disease, right? I mean, that's persistent. Would you expect that you're still going to get hypercalcemia?
I would say that that's definitely a possibility, but I would suspect that given how his levels have responded very well to the resection of his parathyroid adenomas, that it may be manageable with simply lifestyle changes, that these have been described in the literature.
So this may all along been just the hypercalcemia was related to the primary hyperparathyroidism and not really to the this enzyme defect that you're talking about?
I would not necessarily believe that to be the case. My suspicion is that he had a baseline level of hypercalcemia that was mildly elevated, that was subsequently hyper-accentuated by his subsequent development of primary hyperparathyroidism.
You should track this guy in the summer and the winter. If it's D3 degradation, you might get hypercalcemia at the end of the summer. It might, I don't know, might be an interesting follow-up to this.
I appreciate that. That's something we'll look into.
All right, well, thank you very much. Excellent case. The next case is going to be by Rui Zheng Paiwell from Wake Forest University.
Hello, thank you for having me here. I'm a Surgeonk Fellow at Wake Forest, and I'm excited to share our case, Holy Moly, the unexpected saga of an incidental adrenal mass. And we have nothing to disclose. So our story starts with a 44-year-old male who presented to the ED with a history of 1 week's worth of right flank pain, acute onset, persistent, with dysuria and polyuria. Past medical history, overall non-contributory. Surgical history, only significant for a laparoscopic cholecystectomy. And family history is non-contributory as well. His vitals at presentation were all within normal range. Labs only significant for AKI with a creatinine of 2. And since he was an ED, he got a CT scan. And because of his AKI, they opted to do a non-con scan to evaluate for the cause of his right flank pain. At this time, since it's not the best quality scan and what we would have ideally chosen, what is our thoughts about what that right-sided retroperitoneal mass, what could it be, and what would you want to do next?
MRI and FDG PET.
I heard MRI and FDG PET. Does anyone have any thoughts? Could this be adrenal primary, renal primary, lymphoma, MET? So we were called because he was admitted to medical oncology, and they wanted to know what the best next workup was. And we agreed. We decided to pursue an MRI of the abdomen, specifically characterizing this lesion to see what local involvement also might look like. So starting with the axials, you can see about a 12.7 by 9.5 by 9.7 heterogeneous mass. They described a loss of fat plane between the mass and the liver. And you can see this better on the coronals, that there was substantial mass effect on the intrahepatic, infrahepatic IVC, as well as bland thrombus extending distally from the mass. And that arrow sign there was where it was a loss of fat plane with the liver, and they described no evidence of a claw sign indicating renal involvement. So what would you want to do after this imaging? Full biochemical workup. Would anyone want to do anything specific about the bland thrombus? Oops, sorry. Yeah. So we completed staging because this looks extremely malignant. We got a CT chest with no evidence of metastases. He was started anticoagulation for his distal IVC thrombus. He underwent all the biochemical evaluation with no abnormal findings. And so we actually found that his presenting symptom was a kidney stone with UTI, which has since resolved after the completion of his treatment, and he was getting ready to be discharged. So at this point, would you want to do anything else for him while he's in the hospital? That was performed, I didn't show this here, but it was also negative. That was not shown, but it was also negative.
Can you repeat the question?
Is there anything else you would want to do for this patient before he was discharged? Oh, I'm sorry, 11-deoxycortisol, and it was checked, it was within normal limits. Okay, we did not get a PET scan because the CT staging imaging came back without any evidence of metastatic disease. And so, in summary, at this point, we had a 44-year-old male with what we consider a new locally advanced but not metastatic right adrenal mass, suspected ACC, and we had discharged him for follow-up with 1 month's worth of anticoagulation given his extensive distal thrombus, and for multidisciplinary discussion about operative planning. So how would people want to approach this case? Open, yes. Definitely an open surgery. The transplant assistance. Okay. It was described as a bland thrombus with tumor questionable invasion versus mass effect on the infrahepatic IVC. And I can go back and show you that slide again if you would like to see what that scan looks like.
Can you show us the cable?
I don't have a way of scrolling. I normally would. Slow down the scan. And so that is the intrahepatic, and then here is the start of the bland thrombus extending distally.
You're probably going to need venous bypass for that, right?
Cardiopulmonary bypass.
Venous.
Venous. Yes, cardiac surgery. So we talked to, in case there was unexpected involvement of the kidney, we talked to urology, we talked to surgical oncology, and we talked to CV surgery to be available day of surgery, depending on what we find intraoperatively. So we started with an upper midline Makuchi incision. We started liver mobilization, couldn't complete it due to the adherence to the mass. We then performed a duodenal cochlearization with a full medial visceral rotation to expose the infrarenal IVC as well as the left renal vein for optimal venous control. At this time, we started tackling the posterior inferior border with the right kidney mobilization away from the mass, which actually had a well-defined plane there. But before we could completely mobilize it off the liver, we had surgical oncology in the OR with us, and we thought we needed additional exposure with a median sternotomy for that. Therefore, we called CV surgery to come in, and they helped us with the median sternotomy, and with maximal exposure, we were able to complete the mobilization of the liver with a sliver resection off of segment 6. At this point, the mass felt firm, and the IVC adjacent to the mass felt firm, and we had concern for extensive involvement. We had discussed prior to the case where we thought maybe it would peel off, and the OR was very clear to us that it would not peel off the IVC. So just to determine whether or not we would do a reconstruction, he underwent a TEE and a pericaval ultrasound that showed that the infrahepatic to juxtarenal IVC was occluded with no options for reconstruction. There was extensive thrombus from the right atrium all the way down to the iliac bifurcation. And up to this point, this man was asymptomatic despite this obvious cable occlusion, and anticoagulation did not work. So we thought it was safe to do an IVC ligation. So after this discussion, it was removed en bloc with the IVC, and an extensive thrombectomy performed proximally and distally. We took care to ensure both renal veins were patent, and then we closed after coming off of cardiopulmonary bypass.
Rui, where did you ligate the IVC?
Infrahepatic, just below the liver, and just juxtarenals, we had to do a bovine patch repair on that particular segment and oversewed it. So it's right at where the renal veins came off to right below the liver.
So there was clot, though, right there? and
That
you
was
just-
all tumor, so
Yeah.
clot was proximal and distal to that.
All right, continue.
So this is what the specimen looked like as we passed out the pathology. Oriented as labeled, the shave off of the liver was highlighted in yellow as the 7th/6 partial hepatectomy. The IVC, or what is left of the IVC, is highlighted by the white outline, so there was no reconstruction options, and it was extensively involved with tumor. So overall, it was a 12-hour case. EBL was 1.75 liters. We used a total of 8 packed reds, 2 FFP, 2 cryo, and 2 platelets. Aortic clamp time, peri-bypass was 252 minutes. Total bypass time was 292. He was discharged home actually post-op day 8. His only complications while in the hospital was recurrent AFib with RVR that was non-responsive to medical cardioversion and required DCCV. And as part of his workup for persistent tachycardia, he was found to have an extensive PE and recurrent DVTs despite extensive thrombectomy.
So let me stop you again. So let's just get back to the IVC. So you ligated it at the renals, and some of it came out with the specimen. So where did you take it up top, right below the hepatic veins?
Right below the hepatic vein.
But there was clot that went into the right atrium, so you pulled that down, or what
Yes,
happened to that?
so there was no backblading because he was on bypass at that time. So with the veins open, that's when CV surgery basically did a balloon thrombectomy, pushed down from the, where they made the atrial appendage opening, pushed it down, expressed it through the abdominal opening, and then they did a balloon thrombectomy distally from the iliacs.
Okay, and so now the IVC just ends right above
Correct.
the renals. Okay.
Correct. And so pathology ended up showing a Ki-67 about 40%. Interestingly enough, SF1s, naptophysin, calreticulin, inhibin were all negative. It ended up being strongly positive for melanoma and SOX10. And so what do we think we actually ended up taking out? So this is all significant for a melanoma marker. So it ended up being a metastatic melanoma, oligometastatic to the right adrenal gland. So we revised what we're dealing with this patient. He's a 44-year-old male with metastatic melanoma of unknown primary to the right adrenal gland. He has no known history of melanoma in the past, which we had confirmed when he first came in. We performed a PET at that time from head to toe, no evidence of any primary or distant uptake. He saw derm, which had a negative skin exam. He is about to get scoped, I believe tomorrow. It took over a year to get him to scope because he's not a very compliant patient. He has not undergone a fundus exam to look for any melanoma from the eye. And MedOnc has actually completed 1 year of adjuvant ipi-nivo with him. He's on maintenance nivolumab, and he is NED to date. No, he's asymptomatic. The medical oncologist called and it's like, what did you do to this man? Does he not have an IVC? And we said, yes, he doesn't have one. He's like, you could not even tell. So he's very asymptomatic from that standpoint. Yes.
Saray?
Yes.
That one was an IVC sarcoma, so, and she did great too. She died of other things later on, but.
Yeah. Yes, sir. So to just kind of highlight what this would mean, 1 to 3% of adrenal incidentalomas in a patient without a history of malignancy are metastatic disease. And if you look at the rates of ACC with biochemical workup, 60 to 70% of them are either secreting steroid precursors or cortisol. Adrenal melanomas can present with metastases to the adrenal glands. Very rarely are they of unknown primary, and only 6% of those with unknown primaries present with isolated adrenal metastasis. So this actually is good for him because adrenal mets are very resistant to any type of systemic therapy, and there is actually data suggesting improved overall survival benefits should you actually do a metastatectomy. So thank you for your time, and I can take any other additional questions.
Great job, Roy. Yeah, I had a patient just 2 months ago who had melanoma of the left adrenal, and a large mass next to the heart. And the heart one responded really well to checkpoint inhibitors, but the adrenal never went away. Got radiated, started growing again. Then they asked me to take it out, and that was kind of a big deal. It was on the left side, required a distal pancreatectomy, splenectomy, and nephrectomy. And while we were there, we got through the diaphragm so I could take out this little scarred down node that was like a pericardial node that previously had been a 7-centimeter adrenal lesion, or not adrenal, melanoma, and the primary was never found. So I don't understand this resistance in the adrenal gland, but I think one of our speakers yesterday talked a little bit about that and cortisol production and so forth, maybe causing it a good site for that. I don't know. It's a very interesting case.
Jim?
Yeah.
Oh, sorry. Over here. Do you
Yeah,
have, or I don't know if, are we behind time, or can I?
No, you're
ask
good.
a-
No, go.
Just curious, question and a comment related. You didn't biopsy this, obviously. Did you consider biopsy? We need.
Bring her the mic, Rich.
It had come up in discussion. It had come up in discussion on whether or not we wanted to biopsy it. Since our working differential at that time was ACC, we didn't want to.
So that was the point I was going to make. I think the rules that we go by should change. And I don't know, I haven't really talked to a lot of people about this, but about sort of not biopsying these big, large adrenal masses. You rule out a pheo. You don't want to biopsy pheo. If it's, making cortisol and it's kind of more obvious ACC, then don't biopsy it. There's no point. But for other tumors, I think we should do, and I've started to do many more biopsies, seen a bunch of different things, leiomyosarcomas.
Yeah, liposarcoma.
And other, sometimes benign, it's a ganglioneuroma, may change the way you approach the patient or the operation. And
Yeah,
I think our paradigm should change.
And for this melanoma, you might put them on checkpoint inhibitors and saw
Right.
what happened. But as we are learning, maybe they're resistant, but that was a heck of a case, Rui. You guys did a great job. Okay, next and last case is going to be by Kristen Trone from Duke. She's going to give a case called the nervous thyroid.
Good afternoon, everyone. As was mentioned, my name is Kristen Trone. I'm the endocrine surgery fellow at Duke University. I'll be presenting our case, nervous thyroid, on behalf of my whole team. My attendings, Dr. Monreal, Kazare, Sherry, and Dr. Stain. We have no conflict of interest or relevant disclosures. So we start with a 48-year-old patient. She had a past medical history of just depression, anxiety, and alcohol use disorder. She had a past surgical history of a resection of a left neck mass 10 to 15 years prior. And her initial presentation was found incidentally. During a trauma workup, she was found to have a right thyroid nodule. When she was seen in clinic, she described no globus sensation or symptoms of hypothyroidism, but she did note some mild hoarseness. And then her workup was notable for normal thyroid function panel. We did a CT neck and ultrasound, and a direct laryngoscopy was performed and was normal. Of note, she has no family or personal history of thyroid cancer. So her CT neck shows a 5-centimeter solid right thyroid mass without any cervical lymphadenopathy. And then we performed an ultrasound, which redemonstrated this large right thyroid mass with an iso to hyperechoic echo texture. It was classified as ATA intermediate risk, and thus an FNA was performed. The FNA was categorized as atypia of undetermined significance. On the smear here, you can see chronic lymphocytic thyroiditis. These purple tangles at the bottom are characterized as lymphoid tangles. And features of atypia, which included crowding of cells, oncocytic changes, and lack of colloid in these cells. So I'd love to hear discussion about what studies you would order next and what you would be looking for in those studies. Okay. Dr. Zipperstein said molecular profiling. Anything else you'd order? Oh yeah, the left neck mass was, she described it as a glomus jugulare tumor. So we did molecular testing, as was said by Dr. Sipperstein. So we sent a ThyroSeq of this specimen, and it was described as positive. However, no mutations were noted. Interestingly, they did note that there was a high expression of chromogranin A. So, initial clinical concern. What's your differential diagnosis? What else would you order? What's that? Calcitonin. Okay, awesome. Anything else? A dotatate scan. Anything else? Okay, check SDHB. We'll send that, but it won't come back for a while. Anything else? Okay, those are some great answers. We also thought about medullary thyroid carcinoma, so we checked a calcitonin, which was low. We checked a serum chromogranin A, which you might suspect was high. We also ordered plasma metanephrines, which were normal. And then someone mentioned a PET dotatate, which I'll review in a second. Anything else you would order? CEA. CEA wasn't ordered, actually. Anything else? I thought I heard something in the back. PTH. Did you just say that?
The gene expression profile should tell you whether these are cells of follicular thyroid origin or not.
It was not. It was not. No. No thyroid follicular cells. The questions are about follicular cells in the thyroid on gene profiling. What was that? Oh, I'm hearing paraganglioma. Okay, metastatic neuroendocrine tumor. A squamous cell carcinoma. This is a very broad and good differential. Okay, we'll do the PET dotatate. It is going to click through one more thing, which is urine catecholamines. No one mentioned this, but we ordered urine catecholamines and the dopamine level was high. So we ordered a PET dotatate scan, as was described, and there was significant radiotracer uptake in this large thyroid mass on the right side of the neck. Anything else you want to know about the PET dotatate?
Yeah, the rest of the body.
Okay, so there was also radiotracer activity bilaterally at the carotid bifurcation, as well as the level of C2, as you can see here. There was also radiotracer activity at a small mass above the right kidney. Any thoughts about what this might be? SDHB, okay. And then what operation would you offer the patient? Any thoughts on what you might offer the patient with all this going on?
What was his complaint? What did he present with? Yeah.
This was found incidentally.
So, he's fine.
Point taken. We offer the patient a right thyroid lobectomy. We found, as often is found with what we presumed may be a paraganglioma, dense adhesions to the esophagus, cricoid cartilage, and cricothyroid muscle. Tumor was found encasing the recurrent laryngeal nerve, and in fact, the nerve sort of grew through the tumor and then splayed out entirely. This was sacrificed, this nerve. There was very high vascularity in the tumor, and of note, the patient was hemodynamically stable during the operation. So this, on final pathology, was found to be a paraganglioma within the thyroid. It was 6 centimeters, with a background of chronic lymphocytic thyroiditis. On this slide here, you can see a feature that's classic to paragangliomas, which is this clustering and sort of swirling of cells, which is called zolbalin. It's something we see in paragangliomas. A couple of other, couple of other stains that I'll show you here are the TTF1, which was negative, which indicates no thyroid tissue in the tumor, and CK7, which also helps us rule out thyroid. And then the synaptophysin is a marker for neuroendocrine, and so that was positive. SDHB was mentioned, and actually our institution stains for SDHB, and this was retained, so not mutated. Anything else you'd like to know? Yeah, so the patient had an SDHD mutation. The patient also, her sister also had a history of a glomus jugulare tumor in the past, so SDHD was mutated. Postoperatively, she did quite well. She required ENT consult for vocal cord therapy, and then her urine dopamine level normalized months after surgery. Well, immediately after surgery, it was checked months after surgery. So the take-home points for this case are that paragangliomas arising in the thyroid are rare. They're in the literature, but rare, and may mimic other thyroid neoplasms on initial cytology. Hereditary paraganglioma syndrome, such as SDHD mutations, present with multifocal tumors and familial paragangliomas. Surgical management can be challenging due to local invasion or proximity of critical structures. Thanks, and I'll take any questions or comments.
So glomus jugulare, that's in the temporal bone, right? I mean, how would they get there through the neck?
The glomus jugulare tumor was in her left neck near her carotid bifurcation.
Well, that's a carotid body tumor, right? Isn't a glomus jugulare in the temporal bone up into your ear? Anybody an expert? Nancy?
These are the classic non-functional paragangliomas in the head and neck that are classic with SDHD mutation. I think that often we just watch and observe these. I think this one was acting in an aggressive way, so that's what led you there. But the idea now is what next for the rest of that uptake, right, and the rest of that scan. I mean, this is where she's asymptomatic and you do nothing, but there's the new drug belzutifan that's out, right, for metastatic pheoparaganglioma, and just looking at responses. So you just want to make sure you monitor that for the rest of those, because the neck ones usually don't become problematic, but the other ones and the rest of the body may. But good case. Thanks for sharing.
Thank you so much.
Yeah, I mean,
she's
Jim,
being followed closely.
Jim, the glomus jugulare could be anywhere along the jugular vein. So you can see them lower in the neck also, not always by the temporal bone.
Okay, thank you.
Out of curiosity, did any of her psychiatric disorders improve after surgery?
I don't know the answer to this. I haven't seen the patient very recently, but she's being followed for the other tumors, but I'm not sure. Thanks so much for that question. That's a really good one. Okay, thank you very much. What was this? We didn't reconstruct it. To be totally honest, it sort of disappeared is the way we were describing it. Because these arise from the nerve themselves, the nerve was growing into the tumor and then very much splayed out and was no longer a discrete nerve within the tumor. Okay, thank you very much.
Thanks, everyone, for fantastic presentations. Dr. Howe, right on time. I think the first time ever. So this concludes day 2.